Welcome to the State Health Registry of Iowa's video training library series on colon cancer. I'm Lori Summers, the trainer at the Iowa Cancer Registry. This presentation covers the SSDI, the site-specific data items for colorectal cancers. Remember that grade is an SSDI. And the main thing to remember when you're grading the clinical path and post-therapy are the time windows when you're looking at those three fields. There is no longer a generic grade system for any of the sites. I've also given you a copy of the grade manual link here, and it has more detailed information than what I will cover in this presentation. The grade clinical field cannot be blank. You are assigning the highest grade from the primary tumor during the clinical time frame. G4 does include anaplastic, and then note 4 tells when you will code a 9 if the grade from the primary site is not documented, or if workup is not done, or if it's not applicable on the CAP protocol. Note 5, if there is only one grade available and it cannot be determined if it's clinical or path, assume it is clinical grade and code it appropriately in the grade clinical field, and then code 9 for the grade path and blank for the post-therapy grade. For the grade pathological, this cannot be blank. Note 2 reminds us to assign the highest grade from the primary tumor. If the clinical grade is the highest grade, use the grade that was identified during the clinical time frame for both the clinical and the path. This does follow the AJCC rules for a pathological time frame. That does include all of the clinical time frame information plus the resection. If a resection is done of a primary tumor and there's no grade documented in the surgical resection, use the grade from the clinical workup in the grade path field. If a resection is done of the primary tumor and there's no residual cancer, use the grade from the clinical workup in the grade path field. Remember, you can only bring down the clinical grade to the path field if there's a resection done. If you look in note 4, it says you'd have to code 9 when there was no resection of the primary site. So even though you have a clinical grade, if there's no resection, you cannot put the clinical grade in the grade path section. You have to code that a 9. Also, if there's neoadjuvant therapy followed by a resection, your grade path will be a 9. Or obviously, if you only have a clinical case only and only have a clinical grade. Okay, let's look at the grade post-therapy. This is going to be blank for the most cases, because if they don't have neoadjuvant therapy, or if it's a clinical or path case only, or if there's only one grade available and it cannot be determined if it's clinical path or post-therapy. Also assign the highest grade from the resected primary tumor after completion of neoadjuvant therapy. So this is where you'll put a grade from a resection if the patient had neoadjuvant therapy. When you're coding the grade clinical and grade path, think about you're coding the grade from the tumor, not the specimen. So you want the highest grade overall for that tumor for your grade clinical and grade path. Your grade path if you have a resection, will never be less than your grade clinical. It will be equal to or higher. Here are the grade tables for colon. You won't ever have to go look to find these because these are schema driven. So it's colon uses the generic grade table. Okay, now let's start in with the SSDIs for colon. These two kind of go hand in hand, the CEA pre-treatment value and interpretation. When texting the SSDI, this information goes in the lab section on your software texting fields. So you can see by what we collect that you need both the value and the interpretation texted in order to code the information accurately. So take these values from the same lab test. If you don't have the test, but the physician states a value or an interpretation, you can use that. Code the highest CEA prior to treatment or prior to a polypectomy. So if you have a pre-treatment CEA, the value, you would code that as a 7, but they have not given you what the range is for a normal range. So your interpretation is not documented and you would code a 9. You will immediately notice the codes are different lengths, different decimals in all of the SSDIs. This is probably the most challenging thing, moving from site-specific factors where they were all coded to a 3-digit, and now we are coding actual values. The example on the screen, on the previous slide was a 7 value, and so we coded that to 7.0. We're coding, recording the value to the nearest 10th, the highest CEA lab value. And then here are here's information for the interpretation. Make sure that you are texting the date so that we know the interpretation, and be sure to text the normal range if you have it to verify the interpretation. When the SSDI changes came out for version 1.7, this code 3 got updated so that if you have a CEA value documented in the record, but no interpretation, you will code it as a 3 because you do not know what the normal ranges are, and the physician is not telling you if it's normal, positive, negative, elevated, normal. Here are some examples of clear and concise text documentation. We will assume the numbers texted are in nanograms per milliliter unless stated otherwise. So these are all acceptable ways to text your CEA value and interpretation in the lab section on your abstract. All right, so let's look at these examples and code them. The rounding rules in the SSDI manual have been revised for version 1.7, and so those do apply to our 4th case here. So in the first example, the CEA is 2645, and so when we put that value in, because we're coding this or entering this to the nearest 10th of the highest, it would be 2645.0, and we know that's a high value because the text tells us that. So that interpretation code would be a 1. Looking at the CEA 0.50, which is negative, So we're coding that to 0.5 for the value and entering 0 for the interpretation. The CEA 54 would be entered as a 54.0. And it is, we have a normal range and it is high, so we will code the interpretation as a 1 for high. Now this last one is 18.35, and the rounding rules say to round up, and so we would round this to 18.4, and we know that is also high. The general guidelines in the SSDI manual cover all of the sites. If there is a site-specific rule in one of the SSDIs that tells you do not round, drop the final digit, then you would do that instead of heeding the general rules. Anything site-specific in the notes for these SSDIs override anything in the general rules. Here's a common question for CEA: how to handle a case where you know the pre-op CEA was done and you know the interpretation. For example, it was elevated by a doctor perhaps in the H&P, but the test was done elsewhere and you don't have the value. So the correct coding for this would be the value would be ordered, but you don't have the results. And then you can code the interpretation. The physician stated that this is elevated, so you would code this to a 1. Here are the notes for the tumor deposits. Basically, a tumor deposit is defined as a discrete nodule of cancer in pericolic or perirectal fat, or in adjacent mesentery like the rectal fat, within the lymph drainage area of a primary carcinoma. So it's also without identifiable lymph node tissue or vascular structure. So this doesn't necessarily look like a lymph node, but it's just a tumor deposit. And it could be discontinuous spread, it could be venous invasion, or it really could be a totally replaced lymph node that cancer has completely taken it over. So you can use a physician's statement of tumor deposits if you don't have anything else. Note 3 says to record the number of tumor deposits, whether or not they are positive lymph nodes. And note 4, record X9 if there is a resection done and you have the path report, but tumor deposits are not mentioned. We cannot assume that there are none if it's not stated. Here are the codes for tumor deposits. And so you can see X9 if the path report does not mention tumor deposits or if there was no surgical resection done. Otherwise, we're coding the number of tumor deposits. Okay, perineural invasion. The physician statement can be used if it's microscopically confirmed perineural invasion if you don't have any other information. Code the presence or absence of perineural invasion. This is found in the path report. Note 3, information on presence of PNI. So if the PNI is positive, you can take that from either the biopsy or the resection. However, if the PNI is negative, if it's absent, you can only take that information from a surgical resection path report. So let's look at the codes. If you're coding as 0, that can only be taken, that information can only come from the resection path report. If you're coding a 1, that information can come from a biopsy or a resection. And then code 9 if the path report does not mention perineural invasion or it's not documented. Okay, circumferential resection margin, also known as radial margin, soft tissue margin. There's some other names listed there in note 3. You can use a physician statement if that's all you have. It is a strong prognostic factor for local or systemic recurrence and survival after surgery. So SEER did an audit on this field and revealed some issues with coding this correctly. I've repeated some of the information on several slides just to kind of give you a help and a reminder, and a couple of helpful handouts that possibly will help you get through this. Note 4, we are coding the distance in millimeters between the deepest point of the tumor invasion in the primary cancer and the margin of resection in the retroperitoneum or the mesentery. So the circumferential resection margin is not the proximal end and not the distal end. Remember, we talked about that in the anatomy. So it's not the end-to-end margin. This is the circumferential margin around the tumor in the colon. So we'll take a look at a picture here in a minute. We are recording this in millimeters to the nearest tenth. So if your CRM is 2 millimeters, your code would be 2.0. If your CRM is 2.78, you'll round up to 2.8. If they give you a CRM recorded in centimeters, so a 0.2 centimeter resection margin, you're going to take that times 10 and code 2.0 millimeters. Okay, so if you have a margin that is positive, code it to 0.0. If it states less than 1 millimeters and you don't have a specific measurement, code that also to 0.0. There is a code XX.2 if the margins are not assessed, but the CAP protocol, the summary, has to state cannot be assessed or evaluated in order to code XX2. And note 9, if you have an exact measurement of this margin, it does take precedence over 0.0 and those beginning with the XX codes. So what this means is if your CRM is stated as 0.3 millimeters in the final diagnosis, the synoptic states the margins were involved by carcinoma. They want you to code 0.3 millimeter instead of coding 0.0. And note 10 gives where we can code the XX.9 if we have an in situ tumor or the CAP protocol. It's not applicable. If the path report only describes those distal and proximal margins, or if it states margins NOS are negative, that is not enough to code the circumferential resection margin. Only specific statements of the CRM are collected in this data item. And sometimes the CRM is just not mentioned in the record. So then you would have to code the XX.9. Okay, so looking back at this diagram of the CRM margin, we're talking about the margin around the tumor circumferential. Look at the tumor in example A and example B. Then look at the measured distance from the edge of the tumor to the radial margin, which is the incision through the mesenteric or pericolic fat or retroperitoneal fat. In the pictures above, the surgical resection The radial margin is the uneven, jagged, light blue line. So they've cut around this way, around the lumen of the bowel. Here's the tumor, and we are measuring from the edge of the tumor out to that circumferential margin. Of course, in surgery, the goal is to have clear margins without cancer being present. And it's been found that tumor involvement of the radial margin is a strong prognostic factor for local or systemic recurrences, as well as survival after surgery. So of course we want the distance between the tumor and the radial margin to be adequate, or ideally negative. So in diagram B, you can see the edge of the tumor to the blue line is much closer than in diagram A, where you have a larger distance or a larger radial margin. In millimeters, we are measuring that distance between the tumor and the resected margin. So here are the codes. If the margin is involved with tumor, or it's described as less than 1, the code is 0.0. Otherwise, you're coding the distance of tumor from the margin in millimeters. And if you use XX2, that is when the cap has to state that the margins cannot be assessed. Then we have some at least codes. So if the tumor is described as at least or greater than, we can use these XX.3456 codes. If there is no resection of the primary site, XX.7, and if you use that code, then your surgery code should be 00. There's a question about neoadjuvant therapy, and a patient had a colon biopsy. The neoadjuvant therapy was followed by a resection, and the resection radial margin was negative after neoadjuvant therapy. So the question is, can you use that radial margin? And according to Jennifer Rule, who is the overseer of these SSDI rules, the manual does not state that this has to be prior to neoadjuvant therapy. So yes, you can use that radial margin following neoadjuvant therapy. Also below that link, if your surgery codes, so your site-specific surgery codes are 00 to 29, there's no resection, then your radial margin SSDI should be coded to XX7, no resection of the primary site. If your surgery codes are 30 to 80, then your radial margin cannot be coded to XX.7. So those need to be consistent, and that will be a good interfield edit for you to double check when you're coding those. The next two slides are extremely helpful. Amanda used these in her presentation when she showed us the audit results of this value in this field. And I thought it might be a good helpful chart if you want to print these out or keep these handy. It just adds in the codes in the description and also the help over to the left. The main thing on the next slide is when there's no surgical resection of the primary site, you will code the XX.7, and you need to remember that a polypectomy only is not considered a surgical resection. So a lot of times the physicians were stating that the patient had a polypectomy. The pathologists were documenting the radial margin on the polypectomy. However, for purposes of this field, the CRM data item, the polypectomy will no longer be coded as a surgical resection. So keep that in mind. Okay, so note 3, going back to just reiterate again, here are some terms. Only specific statements about the radial margin or the circumferential radial margin are collected in this data item. So on the left are the green terms that you can use. These are okay. And do not code the CRM if these are the only terms that are found on the right under the red header. So if it says distal or proximal or margins NOS, that does not fit this field. Or even if they just say all margins are negative, or the resection margins are negative, that is not enough to code the CRM. It must be explicitly stated for this data item to be coded. And again, if you have trouble converting centimeters to millimeters, you can use the Google calculator that will convert for you. Or remember to just move your decimal over 1/10, 1 unit to the right, and that will give you your millimeter. So this is one area where I know that it's sometimes easy to just grab the number that you have in the chart and not realize that they've given you centimeter instead of millimeter. And then looking at note 9 again, if you have an exact measurement, code it. And so that exact measurement will take precedence over code 0.0 for those radial margins that are positive, even if the pathologist states the margin is positive. If you have an exact measurement, do take it. So again, the example below, the radial margin is stated as 0.3 millimeters. The radial margin synoptic states that it is involved, it's positive, and it's less than 1 millimeter from the margin. But since we have an exact measurement, we will take that instead of the 0.0. If you have CRM given to you as a range, then you will code the next unit up. So if you have a range, you code 0.1 above the lowest number in the range. The distance of the invasive carcinoma from the closest margin is 3 to 4 millimeters, and it is a radial margin, and so you would code the 3.1, go up 1 unit of what we're coding. So since we're coding to the 10th millimeter, you would go up 1/10 for this field. If the CRM is given as greater than statement, you code 0.1 above the number provided. So remember, code XX.6 is actually if it's greater than 3 millimeters, or it's stated greater than 3 millimeters. So that doesn't apply. The example below, if it says it's greater than 1 centimeter, that's when you're going to use this rule to go up 0.1 and code it 10.1 millimeters. Because 1 centimeter is 10 millimeters, and it says greater than, so we'll go up to 10.1 millimeter. If the CRM is given as less than, you would go down 0.1 millimeter below the number provided. So in this example, the distance from the radial margin is less than 3 millimeters from resection, so you go down to 2.9 millimeters. All right, I think that's enough on CRM. Let's keep moving through. The next one is KRAS. So this is an oncogene that mutates and causes normal cells to become cancerous. It's often present in colon cancer. You can use a physician's statement of a KRAS when you don't have anything else. It's commonly done in a metastatic setting. Results from nodes or metastatic tissue can be used for a KRAS. If the KRAS is positive but there's no mention of the mutated codon, or it's not specific, then you will code a 4. So let's look at the codes. Here's what we're looking for. We're looking for an abnormal or a mutated codon in the KRAS. So if the KRAS is reported as normal or wild type or negative for mutations, that would be a code 0. Unfortunately, the lab is not going to tell you the KRAS on codon 146 is mutated. It's going to take a little bit of digging, but SHRI has clarified this area for us and will be giving us some better instruction on how to dissect that out. First, let's look at an example of what we're looking for in a KRAS, and actually what do we text. So this is a KRAS report. The KRAS alteration is detected. Down here in this genomic alteration line, you will see hidden here a 12V. And so that means that the codon 12 is abnormal. Also, here's the interpretation. The genomic alteration in the KRAS gene is detected, and it's giving you this string again. So this was a question on the forum, and the answer was this looks like a G12V, which is a codon 12. So in this example, we would code KRAS to a 1. So if I were going to text this, I would text the date. I would text alteration is detected in the KRAS, and then I would probably text that genomic alteration string, that C.35G greater than T colon PG12V. And that's probably all I would text. The following will be added to the 2021 update of the SSDI manual. This will not be updated for this year. So there are 4 KRAS codons that are commonly mutated in colorectal cancer. This SSDI does not record the actual mutation. Instead, it records the codon or the codon groups that are mutated. So if you have a codon 12 mutated, these are the things you will be looking for in the KRAS report. Same thing with codon 13. Here are the values that you will be looking for to tell you that the codon 13 is altered. Here's codon 61, codon 146. So I think those will help us not only knowing what to look for in the report, but also what to text. Okay, moving on to the microsatellite instability, the MSI. This is a genetic test used as a prognostic marker for response to surgery and survival. Under Note 3 and Note 4, it gives very detailed information on the MSI in Note 3 and on the MMR in Note 4. And so if both of these tests are done and one or both is positive, code a 2. If all the tests are done or negative, then obviously code is 0. So here are the codes, and this is what they're talking about with the MSI, the microsatellite instability, or the MMR, the mismatch repair. And oftentimes in the mismatch repair, you will see the proteins listed out. And those aren't really in this section to help you identify what you're looking at and what you're trying to find. So here's an example. Remember that the MMR is done by immunohistochemistry, or IHC. If the MMR is intact, it will be a 0. If the MMR D means it's a loss of expression, or deficient, you would code it to a 2. Or if the MMR studies weren't done. So here we have a mismatch repair protein markers, and these protein markers are not the same as the MSIL or the MSIH on the previous slide. So then the path report goes on to tell us that these are positive, representing an intact mismatch repair protein. So all of these are intact. So the MSI for this case would be a 0. It's all intact. And I would probably text the date and MMR intact. That's really all you need out of this report. Sometimes it's a challenge. You want to text in all of this information on these proteins. If you want to, that's fine, but you can see that all you're really looking at is what the information is and what the value is. The exercises for the SSDI section of this video are located on the SEER Educate page. Under the practical application section, there are 10 colon and rectum SSDI exercises. There are also 5 grade exercises for colon and rectum. And I encourage you to get familiar with those and gain some confidence as you start working through the colon and rectum SSDI. Here's my contact information if you have any further questions. Thanks for listening.